Well, good afternoon, everyone, and welcome to the Family and Community Medicine Grand Rounds for June. We are really delighted that you've joined us today and that we're going to have a really highly recommended presentation today. I'm Megan Mahoney, and I'm the department chair for the Department of Family and Community Medicine at UCSF. And it's my privilege to, introduce our speaker today. Before we get started, I'd like to make a few quick announcements. First, please note that today's session will be recorded, so just be mindful of that. Secondly, following the main presentation, you'll be able to ask questions using the Q&A function on Zoom. And then I also wanted to alert everyone to our next Grand Rounds. This will take place on August 7th, and we will be hearing from Dr. Sandoz Al-Sad, who is a faculty member here. She will be leading a presentation on the menopause connection. Menopause is a natural part of life, and it is not often understood well. And in this talk, Dr. Al-Sad will help make menopause easier to understand by breaking down the common myths with clear science-based information. Dr. Al-Sad explains what we currently know about menopause, where there are still gaps in care and in research, and why menopause should be viewed as part of a person's overall health, not just a single life stage. The talk will also highlight the importance of a more connected, whole person approach to supporting people through menopause. As I mentioned, Dr. Al-Sad is a member of our department, and she works at the Women's Health Primary Care Clinic. She's a nationally certified menopause practitioner and she's certified by the Menopause Society, and that equips her to provide the most current and up-to-date clinical service to women who are going through this transition to menopause. So hopefully we'll see you there. I also just had one last reminder that in case you missed any of our previous Grand Rounds, you can watch them on YouTube. Please join us, join the website, and using this QR code or using that URL link, and you can see the list of upcoming speakers as well. And if you have any suggestions or nominations, please email us at familymedicine@ucsf.edu. I also wanted to thank Dorothy and Linda for their help today and setting up this presentation. So now, without further ado, I'd like to introduce our speaker, and I'll just start off by just saying how thrilled we are that Dr. Catherine Gauthier is joining us. She is an assistant professor in family medicine and a medical educator at Aga Khan University in Kenya. She teaches across undergraduate and postgraduate training, contributing to curriculum design and delivery with a focus on clinical reasoning, communication skills, and interprofessional education. Her work includes integrating generative AI into medical education, particularly through the use of AI-driven patient simulations to support skills training in diverse and resource-limited settings. On a personal note, I will say that there's nothing more gratifying for the educators and those who are committed to a life in academics than seeing someone that you had a small part in their training and see them become so successful and become an international voice. And that is, been my experience with Dr. Catherine Gauthier. I had the privilege of working with her when she was a resident. And it's wonderful to have her join for our Grand Rounds today. So welcome, Dr. Gauthier.
Thank you so much, Dr. Megan. Let me. Um, all right. Thank you once again, Dr. Megan, for that very warm introduction. And to be quite honest, I also wanted to take this opportunity to acknowledge you. You didn't just play a small part, as you put it, you played a significant part in my journey as a family physician that I am today, the genesis of who I am. And I've been watching you even from afar off, and I can tell that you're a role model to emulate. And I've been looking at you and saying that, I mean, all along my journey, you're a person I wanted to be when I become a fully pledged family physician. And here I am today sharing a platform with you. Thank you for the years that you invested in me as my first program director at Aga Khan University. And I owe a lot to who I have become today. Thank you so much for that. And even the opportunity to share with other family physicians concerning or regarding this topic that I so dearly love, from both to bedside, and how it is that we are implementing AI patient actors for clinical skills training. I'll share a little bit about my journey and how I ended up here, and how we are utilizing this even in training family medicine residents in Kenya. So thank you so much for the introduction. So in terms of disclosures, I have none to declare. The tool that I'm going to share today is open access and non-commercial, and any of you would be able to access it. Perhaps also just to note that the lead author of the work that we are doing, Thomas Thyssen, has authored a paper around the same work, and has published that in the Medical Science Educators Journal in 2024. Please take time also to go through that, and it can shed more light towards what I'll be discussing more of this afternoon. All right. They say if you want to go far, then you need a team to do that. So we have been working as a team, and I'm so happy to see this collaboration, one between faculty and students, and again, cross-cultural, and I mean, within different schools, from Geisel School of Medicine, led by Thomas Thyssen, to Dartmouth College, and myself from the Aga Khan University in Kenya. And our students, who are our main stakeholders in what we are doing, have also been part of this work. And one of the ways they have supported is by constantly testing the tool that I'm about to discuss this afternoon, and giving us constant feedback, areas that we can improve, because again, this is a tool for them. So having them being part of this sort of co-creating it with them has really gone a long way to enhance it to where it is right now. We also acknowledge funding support. This work has not been without funding. We also acknowledge that from our different partners and collaborators across the world. So what we hope to explore today is just deep dive on what the problem really is. They say if it's not broken, I mean, don't fix it. So then what problem are we trying to fix, or what challenge are we trying to mitigate? Clinical training has already been taking place even prior to the AI revolution. So what problem are we trying to solve? And I think we are going to delve much into that during the talk. What is the AI patient actor? What platform is it, and how does it work? What is the science behind it, and what is the evidence? We are medical educators, we are family physicians, and a lot to what we do is really backed up by evidence. So we are going to look a little bit into that, and how does this cut across the different contexts globally, in low resource settings, even in middle and high income countries. How does that cut across? And hopefully, I would hope that you are able to try out the tools yourself, whether it's during the presentation or thereafter, because again, that's the reason we're sharing this with you, because we hope that you can explore that and hopefully get the benefit that we are also experiencing in Nairobi. All right, so the gold standard when it comes to clinical training for our medical students. For a long time, we have been using the standardized patients, and I know we are all familiar with who they are. They're trained humans who simulate medical conditions, but the challenge is this has not come without real cost issues, especially the cost of training has really skyrocketed. The standardized patients are good because they help us to train our students how to conduct medical interviews. I remember training as family physicians, the heart of the consultation is the communication skills. I remember spending a lot of time being trained on that. So that is at the heart of any consultation, how to formulate differential diagnosis, critically thinking around that. This is the role of standardized patients. You can imagine if our students were just being trained in a classroom and then given an opportunity to go out and test with real patients, that perhaps will not go as well because, again, there's all that, readiness. Sometimes there's even fear. And I mean, they make mistakes, but the standardized patients have really enabled us to train them within a safe place, and they have been able to get formative feedback that has enabled them to constantly improve, especially through the repeated scenarios. Now, they do offer some challenges, and number one being they're quite resource intensive. To put that together, and also logistically, it's quite resource intensive. I have had the privilege of being a program director in family medicine and organize clinical exams from my students. I can tell you it was hectic. It was quite hectic to put all this together, scheduling constraints, and again, they're hard to scale. So with that, then with the AI revolution comes the question is, can this be done differently? And the generative AI now opened up a whole new frontier for clinical training. And for us within this platform that we have co-developed and we are now implementing again across the different contexts, we have found it to be very useful in training our family medicine residents. Currently, the platform has a little over 65 cases and counting. These are clinical cases that have been developed by medical educators for medical educators. They are available to students 24 hours, 7 days a week. And I think there's nothing as good as that. Part of the feedback that we have received is a student perhaps seeking, to do a bit more refresher training, maybe a Sunday night before an exam, or maybe a lunchtime before a clinical exam. And this platform allows accessibility throughout and again promotes student-led learning, and they are able to, navigate the platform at any one time. It is free access, and it has this global availability. And so it uses the same large language models that we know, ChatGPT and Claude. And the key thing is that we use that mainly for their conversational skills, not their medical information, but their conversational skills. And this is an area we found we could leverage on and build the AI patient actor platform. So again, just as mentioned, it is powered by the large language models that I know most of us are already familiar with. Medical students are able to interact with the AI as they would with a real patient. And the key thing is the platform allows different avenues to engage. It could be text to text. It could be, word to word or verbal to verbal. And the LLM is mainly utilized for its conversational capability. The medical content is controlled. It is inputted by the medical experts who are me and you in this context. And then the LLM is mainly used to handle the conversations, which we know are really important to inbuild and help our students and our residents to keep practicing and improving, especially within their medical training. So how this would work is the educators would create the cases within the platform. The students would interview the patient. The AI would respond. And the key thing about this, which I know sometimes as educators we've had a challenge with, is giving that immediate feedback, especially within the formative stages. And also, if you have quite a number of students that you're training, then that becomes quite difficult. But with such a tool, then we are able to scale, we are able to do much more to support a lot more students. All right. So generative AI is not like a magic word. It doesn't come, proving all, promises. We are aware there are pitfalls. But perhaps to start off with some of the promises that it seeks to, provide. One is that it is reliable. The interactions are quite consistent because, again, it's the same interaction that all students will get. I don't know whether you've interacted with some of the standardized patients, and perhaps by the time they're being interviewed by the 10 residents, maybe they're tired, maybe it's at the end of the day, and you wonder whether the student will get the same experience the first student did. Now, with generative AI, we don't need to worry about that because the interactions are quite consistent. Students receive personalized formative feedback. The scenarios are easily customizable, and that's one avenue we have really utilized within the African or Kenyan context because we are able to customize the cases to reflect what we see on a day-to-day basis here in Kenya, which may be different from the cases or the patients you encounter from a different setting like UCSF. So it's a no-code setup. We just use the chatbot, and then it's a very safe space for practice, scalable, and again, it supports this idea of precision medical education. Some of the pitfalls that we have noted, again, is it doesn't really provide realistic non-verbal cues, at least most of them. And then there's limited emotional depth, again, for most of them. And then risk of hallucinations, bias from training data. This is, I think, something that is common with all generative AI. Simplification of complex cases. You can input a case that you think could be a bit more complex if there was a real patient, but again, the AI tends to oversimplify it, and a lot has been blamed around lessening the ability of students to critically think, and that's something that is still being investigated, and a lot of evidence is building around that. And most importantly, that I'd like to add is it cannot replace real patients. Even if we move to robotics and all the other things that are coming up, I don't think there's ever a time generative AI or an artificial intelligence model may 100% replicate a real patient. We do know there is value in still continuing to do that. So the thing is, we are not trying to replace, we are trying to provide an adjunct or a complement to what there already is. So again, in line with precision medical education, we are aware that there's no one size fits all. And sometimes I wonder, the same way for a patient, I would not, even if I'm treating, let me talk about a condition that I'm familiar with here in Kenya, malaria. Even if I'm treating malaria here in Kenya, even if 2 patients present with malaria, it is very less likely that I'll perhaps provide the same dose for both patients. One may be complicated, needing IV, the other may need outpatient management. So again, it may be the same condition, but the treatment approaches are different based on the patient that is in front of you. And I think that's the idea around medical education, tailoring learning for each and every individual student. So again, being able to adapt, and matching the student to, the difficulty level. Are they in their first year of training? Are they in their 4th year of training? So again, this platform would allow us to do that because, again, you can tailor the cases based on that. The beauty about having an AI or such a platform is that there is this data-driven insights. You're able to track progress of each student differently, identify gaps, and target specific skill deficits to that student. And you as an educator, you're able to personalize that feedback and help them to learn. So with AI, this is what it promises us to do. And we can only look forward to how this is going to change even as we continue to train our students from a data-driven point of view. All right, so there are many, the ecosystem of patient actors. We are not trying to reinvent the wheel. We are not saying this is the only platform that is available. There are quite a number. So there are some that we are able to create ourselves, and I'm sure most of you perhaps have already created some yourself. There are those, the custom GPTs, cloud projects, other, open source LLMs. This is something that you're able to curate yourself. There are some that are commercially available. I don't know whether some have interacted with tools like Sketchy, Geekymedix. Those are other tools that are available. And now we have the AI patient actor that is akin to other platforms like the Clinical Mind from Stanford. So the thing is, the key thing about this, again, as I'd mentioned before, one, it is free. So we are not trying to make people perhaps commercially subscribe to that tool as of now. It is free access, globally available, and students are really able to access it, and so are the educators at any one time. And it's again being used within different global context, and hence it has really gone a long way to enrich the platform. All right. I think the key thing that perhaps is important to add, even as we have this conversation, is we are not losing touch of the medical expert or the clinical expert, who is me and you. So the patient case file is hard-coded by a clinician. So we do not rely on any LLM for medical facts. And I think this is one niche or one good feature about this. So in this case, the patient case file being authored by an expert and the professor reviewing could be one and the same person. So the author and the one who reviews, but again, it could be two people. If you're working within the department, you could perhaps allow faculty member to create the case and then another person to review it so that you're able to sort of moderate the case and agree in terms of its level of difficulty. So the clinician is at the heart and at the center of controlling the information that is heard on that is shared or within the patient case file. So again, the LLM is being used for its conversational ability and the ability to create that consistent kind of like interaction with the student. And again, the chatbot, because it's a chat box, it uses the ChatGPT and cloud features to handle the dialogues. And as educators, we are able to really control the complexity, and also with the tool that I'm talking about today, the AI patient actor, the persona. We are able to give the patient actor a personality right from their voice to how they are responding. We are able to create scenarios that can mimic an angry patient, because perhaps in that scenario, we are trying to simulate an angry patient. Sometimes it's a bit hard to get these as SPs, or even if we do, perhaps not as consistent as an AI patient actor would. But the thing is, we are able to give the AI patient a persona, and that maintaining academic integrity. And most important, the students have a safe place to practice, keep practicing until they become better and better at the communication skills. Remember, in family medicine, the heart of any consultation is the communication and the consultation skills. And that in itself is what we hope that such a platform can enable our residents and our students to continue building up on. So we'll talk a little bit about the anatomy and the psychology of this AI patient actor platform. So think about the anatomy like the hardware. Again, we've talked about the custom design, the chatbot it's using, the kind of engine, the LLM engine it's using, Cloud GPT, and the other conversational platforms that are there. In terms of input and output, we do have an option within this platform of just text, writing it down. But we do know that texting vis-a-vis a one-on-one conversation with a patient is not the same, especially in building consultation skills. So we do have the option of text to speech, but the one that I love most is speech to speech, kind of like interaction. It goes a long way to mimicking a real life conversation with a real patient. And then how this works is, the system prompt, you'd begin with a prompt, perhaps to say hi to the patient. And then it would go on to retrieve the case file, the rubric that has been fed into it, and then carry on with the conversation. In this case, the chatbot acts like a patient, but you could also wire it, or you could also feed information to it that perhaps it could act like a mother to a pediatric patient that is coming. So you can have it act as different persons, give it different personalities based on the case that you have created. So the psychology is really who you want it to be, in the sense of the personality. What settings, what rules are you giving it? How do you want it to act? What symptoms do you want it to mimic? And then based on the rubric or the architecture that we have given into it, it's able to give us personality based on the Big Five profile, the ocean, and we have configured it within the case file where the educator is able to create this, the case file for the patient. And then you're also able to sort of customize the motivation, the fears. I remember being trained, and I was always asked to always ensure that I explore the ideas, the concerns, and the expectations of the patient, and all that you can feed into this, so that as a student explores this, once they're having the conversation with the bot, which is now acting like a patient, this also is able to come up. So again, all that goes to say that once we are trying to provide as much realism as possible, and the students would almost feel like they're interacting with a real patient. So just evolution of how we've come, in trying to develop this tool or this platform. And so you won't believe that this began, as a Python script on someone's laptop in March 2023. And by the end, or towards the end of that year, around August, we had our first version of the patient actor platform. And around that time, it was trying to load cases, trying to see how the hard coding of the patient case file would look like, adapting it for some of the courses at Geisel School of Medicine. And even at that time, it was still open access, and a few of the students got an opportunity to interact with it at that point. And they gave us even more feedback that has allowed us to create now what we are calling the beta of the version 2.0, which has been done again with the Dartmouth DALI lab. It has had a lot of us co-designing. It has had a lot of us trying the tools out, even in the different settings, so that we can allow as much data as possible to enrich the process, even as we continue to improve it. And for any of you perhaps would be in a place or an opportunity, you can start to look out for it. And I think the link, you can see it down there, patient-actor.dartmouth.edu. Version was looking at, the one that was developed between May 2023 to May 2025. At that time, it only allowed us to use English as a version, as you can see. And at that time, even the speech-to-speech interface had not been very well developed. That time, we were doing a lot of text-to-text, kind of like conversation with the AI patient actor. But we had a dream, we had a vision that with time, we would want it to be able to demonstrate conversational abilities in different languages. And I'm glad to report that the current bot that we have, the second version, version 2.0, is able to interact with a little over 52 languages. So it's very likely it can cut across different nationalities, and one would be able to find a language that they can relate with, they can communicate with within the bot. And right now the text-to-text version is available, but I find a lot more of my students preferring the speech-to-speech because it really mimics how a real patient would be able, how they'd be able to converse with a real patient. So this is how the current platform looks like. This is, again, the version 2.0. This is what we have been using from May 2025 until now. And again, that you can log into the site patient.actor.dartmouth.edu and perhaps start to explore it. Of note is, again, you can create an account. It's free of charge. But currently, if you create an account, as you will see, as a student, you would need a code that would allow you to start interacting with the cases. We've done a lot to protect its integrity, in that we only allow students or faculty sort of trying it out to interact with the student platform, and only educators to interact with the educator version, just to maintain its integrity, as I'm going to show you in the next few slides. Feel free to just, interact with me, pose a few questions that you may have, even as we watch this small introduction video that will shed a lot more light in regards to this platform.
This is AI Patient Actor, an open access platform built at Dartmouth for clinical communication training. Educators have their own portal. From here, they manage courses, author new cases, and review student progress. Creating a case is straightforward. You fill in the patient's history, personality, and communication style, then define the rubric you want the AI to grade against: rapport, history taking, clinical reasoning, and more. Every course gets a unique enrollment code. Share it with your students, keep enrollment open for as long as you like, and assign cases for the week. On the student side, they enter the code, and the new course appears in their dashboard. They pick any case the educator has assigned and choose text or voice mode. In voice mode, the patient responds with real prosody and emotion. A sidebar tracks encounter tasks, diagnostic tests, and a pad for SOAP notes, all rubric scored behind the scenes. The moment the student finishes, they receive formative feedback, rubric scores, narrative coaching, and for voice encounters. Feedback on not just what they said, but how they said it. Unlimited practice, 52 languages, immediate feedback, simulated patients, real learning.
I hope that has given you an idea about this. And just going back a little bit into the educator, because the educator portal is the opportunity for you and I to customize. So first of all, there's no coding required. You just describe your patient in plain English, enter the demographics, the complaint, history, exam findings, all in plain English. But again, you're feeding it to an LLM, so it's able to generate its first draft. With every draft, you're able to customize, you're able to change and really ensure that it reflects the real patient that perhaps you saw or the one that you're trying to create. Secondly, you're able to configure the persona. The personality is a key highlight of this platform, because you're able to make the AI really reflect what you would like it to. Again, if it's, as I said before, breaking bad news, perhaps a sad mother or something like that, or an angry patient, all that you're able to personalize that, especially as you create the case. And then ultimately, you're able to publish to the students using a course code. And on your end, you will be able to track the students' progress in the student dashboard. You'll be able to see how many cases have they interacted with. With time, we even hope we can scale this to even research potential and try to see, does the number of cases that students interact with using this platform reflect how well they perform, perhaps in their clinical exam. This is something you can do, and again, gives us a good area of opportunity when it comes to research. So I want to give you a sneak preview of how my dashboard looks like as an educator. This is what I have been able to create. And a lot more, but this is just a screenshot of that. Few cases that I've created. As you will see, some of the names that are there are Kenyan names. Let me say that these are names of names that we are very familiar with, but customization or adaptation within my cultural context goes beyond names. It's not just about bringing a Kenyan name, but if you open the case, the material there, the information there really reflects a Kenyan context. The diagnosis, some of the conditions there are really what we see on a day-to-day basis within my cultural context. So cultural adaptation is beyond names, but again, it helps. Again, even in the settings where they come from, some of them here live just by the riverside where they draw water from the river. And then that goes a long way in affecting some of the conditions that our students are interacting with. And that really forms a good way for the students to make these cases relatable. They're able to relate with this as they would with any other patient that they meet in clinic. And then we've talked about calibrating the patient personality, which is a key feature that the patient AI platform offers. And for them that may have been wondering what is the big, 5 ocean personality dimensions, it regards to one, openness, a highly open patient would be more curious, more open to the diagnosis that the student in this case would offer. A low conscientiousness would be perhaps more disorganized, one who easily forgets their medication. Extraversion would go on to reflect a person who is, shares a lot. And the opposite would be somebody who is a bit more reserved, that you still want to train your resident how to interact with them. Agreeableness is how they easily agree to what the doctor is saying or challenge that. And neuroticism, again, are they more anxious? Are they more concerned about what's happening to them? And then again, the interpersonal circumflex, again, just goes on to say we can tailor the personality to how we would want the patient to reflect. So you can try it now, or you can take some time, perhaps do a screenshot. You can see whether you can, scan the QR code. Perhaps what you may need to have is the code that I have highlighted in red. Even if you do not wish to explore that now, see whether you can copy the code or type the code 7A and then capital I 3YW. Again, the code is 7A, capital I, 3YW. If you go to this platform, the URL has been shared there. Perhaps I'll ask, Linda and Dorothy and the team, perhaps this is a link they can share with all of you, because we would be very keen for you to try it out and see whether you are able to access the platform. You'll be accessing the student account, and with the code, you're able to go in and try interacting with these cases and see whether they mimic the real patient as you would want that to be for your patient, and then see how the conversation is. And so that perhaps is one thing that you can try out and share with us feedback. Towards the end, I'll give you information about how you can access the platform as an educator. All right. So again, I was trying out the platform just for this demonstration. I think it was a day or two ago. And you can see I was engaging with the platform in Swahili. And I put it in text in as much as I prefer verbal, just to demonstrate this, because you can see if I speak to the platform in Swahili, response to Swahili, I ask questions in terms of clerkship in Swahili, the response is in Swahili. And again, it was, the patient, rather, we were able to have this conversation until the very end, tick off tasks, and actually come up with a diagnosis with no glitches whatsoever. Again, as noted, we have 52 languages there. So even if you're not conversant with English, or you'd like to look up another language, perhaps your native language, please feel free to explore that within the platform and share with us your feedback. All right, so the speech-to-speech interaction really allows us to gauge and record prosody, so that is scored against the person's persona. So students speak naturally, there's no need for typing, and then we are able to provide a prosody analysis. Again, this is something we are still working on. It's not perhaps something that we'll get right now, but it's something we are building on. And the key thing from now, what we have is the feedback that is immediate and specific for the student who has been interacting with that platform. So, and this is what the students really love the most about this tool, because they're able to get perhaps quicker feedback than we, the faculty, would give them. And again, very relatable and very real, because again, it's reading based on the interaction with the chatbot. So in future, our hope, and again, the hope of AI is perhaps one time we can create quite interactive AI avatars, because right now, as you have seen, the platform is more of voice and text, but hopefully with time we can actually create an interactive avatar that can go a long way to mimic how a real patient perhaps would be looking like. But I think providing a face to the conversation is the next step that we are looking into building within this platform. This has already been experimented in other places, like, for example, Gaze School of Medicine introduced this to their first-year medical students. That was in 2024 in their own doctoring course. It's a course they have. And the students, these are the main themes that were picked up from the survey that was shared with the students, is that highly recommend or highly goes out to provide opportunities for practice and reflection, provides opportunity for immediate feedback. I think that is the key thing about this platform. They acknowledged a bit of technical issues and frustrations, but at that time, remember, we were in our first version. I'd be happy to try it again with the same students and see what they would say about that. It enhanced their clinical reasoning, and again, they still noted, in spite or in addition to having this, they still preferred real patient interaction, which is good, because as we have said, we are not actually trying to replace that. We are trying to augment or put it as an adjunct to what they already have. So there is data that has been published in New England Journal of Medicine, and they used what we call the ASCII, the AI standardized clinical encounters vis-a-vis students trained within the standard training, and they wanted to see how well they will perform in their OSCE training. And the students who had been trained on AI actually were noted to not only perform better based on their the scores, but also to be more emotionally ready to carry out the clinical examination and more confident. So please check out this journal, read more on it and see the data that it provided, and it can go on to tell us how we can perhaps build this on in trying to train our students or prepare them for OSCE. For now, the platform is mainly at supporting formative skills development and not summative. That's where we are at now, and at least we are still exploring through research perhaps how it can add on in terms of summative training. So again, the bias challenge, we are familiar with that. The LLMs do reflect their biases based on their training data that has been seen in various journal and evidence-based platforms. So it's for us to see then how to mitigate that, and perhaps providing different contexts that can feed information to this LLM is just one way of trying to perhaps see whether we can bridge this bias challenge that has been noted in terms of race, gender, language, and even medical knowledge bias. So, as mentioned earlier, cultural adaptation is beyond language translation. Some of the idioms that we've been able to input, as I feed in my cases, as I try to customize my cases, I'm able to introduce a few idioms that perhaps if I gave a student in Kenya, they know what, we mean. Like, for example, if you say, pressure, I feel pressure. Sometimes a patient says, I'm feeling a lot of pressure. The student is able to understand what that means within the Kenyan dialect or perhaps a local setting. Sometimes we have patients saying they feel malaria-like symptoms. As for us, we know that means fever. They try to tell us that if you hear patients saying, I feel malaria, it just means I feel feverish. And we are able to put that there so that if the chatbot says that, then the patient, the student is able to say, this is what they're trying to say. And again, get a lot more information from that to build onto the case. So the key thing we've been able to train our local educators on is prompt engineering. I think that's the new superpower, the art of prompt engineering. We're also able to get region-specific cases for our setting conditions. And now we have a dedicated AI chatbot for East Africa, Swahili as an option. And again, speech-to-speech interface that allows, even for the low literacy context, one can easily just talk and have that conversation. So it has really gone a long way to provide these adaptations for East Africa, which has really enhanced the training of our residents. As I come to an end, because I'd like to provide a platform or an opportunity for us to engage in questions, in Kenya, we've done this primarily for family medicine for now. One, because I'm a family physician, and I also do know that building their consultation or communication skills has to begin from there. That's our niche as family physicians. So I've been able to introduce that to them. And in fact, just before I started this session, I was able to post a few cases for the students to interact with. Currently, I'm attending a conference in Augusta, Georgia, and so I'm away from my students for about a week, but that does not stop me from supporting them in terms of education material, and I can leave something for them to do. And again, once I go back, I'm able to review what they've done and add on to what they've already been interacting with. So we've been able to author the cases, focus on what East African presentations, and again, language, and we've been able to train a few faculty on this, and the interest is still growing within the Kenyan context. These are some of the research questions that we still need answers on. We do not have the answers to everything. Does it really improve clinical knowledge and skills long term? How does bias manifest? How do we mitigate that? How accurate is the formative feedback that is given? Can it be used for summative assessment? We haven't used it for that yet. And all the other questions that you can see, and perhaps another good opportunity for you to explore this even from a research perspective. So for our faculty, as I said, I'd like to mention this at the end, is for you as a faculty, you would need an educator access key. And for you to do that, kindly for this time, please do not mind to email. You would need to email us at ai.patient.actor@dartmouth.edu. You can either take a screenshot and email that. And please request for that from Thomas Thyssen, is the one who will respond. He's our main lead author of the lead doctor dealing with this or guiding us on this. So he'll be able to verify your credentials as an educator and provide the access key for you, just to, avoid any contamination from perhaps students interacting with that platform. And it is free of charge. All we need you is share that, your email, or write an email to that address, and we'll be able to do that. And then you can create your first case. There's also, you'll be given a link on how to really create your first case, in case what I've shared is something that perhaps you'd like to explore another time. You are able to test and refine, you're able to assign to your students, and you're able to review your analytics that can go a long way to even supporting your students personally. The last slide as we come to an end, the AI Patient Actor is a free tool. Mainly, we use that to train clinical communication and reasoning skills to our students. The professor in the loop is really what keeps us as educators at the center and at the heart of the consultation and of the conversation going on between the patient and the student we are training. Evidence shows that students who actually train on AI have the advantage and can actually perform better on their OSCEs. And in fact, from this study, because it was randomized control trial, when they found that this went a long way in, enhancing and enabling the students to perform better, this was rolled on even to the other students, the control group who had not been exposed to this platform. After the results of this study, they were also exposed to the platform so that they have the advantage of improving their clinical skills due to the, in terms of the results that were noted from that study. Cultural adaptation is essential. You are able to adapt that based on the setting you're in. Bias is real and must be actively monitored. So it's very important to do that. At all stages, training must be monitored. And formative, for now, we've not yet explored the summative option. And most important, we are not trying to replace the gold standard, the standardized patients. We are just trying to complement them and allow students an opportunity to be trained or to be student-driven, to be self-led when it comes to practicing their clinical skills so that they can continue to build up on their communication and clinical reasoning skills. With that having been said, I really want to thank you again, the organizers and Dr. Megan Mahoney, for giving me an opportunity to share this with you. Back to you.
Wonderful. That was such an interesting conversation and presentation. We now are going to invite the conversation. There's been a lot going on in response to your presentation. I noticed that a lot of our colleagues who are on the line here are logged on to the AI patient actor portal, and thank you for clarifying that the code that you gave us is for the student account. And if we wanted to sign up for the educator account, we will email your colleague at Dartmouth, and so lots of interest. There's one question, and I invite anybody else to present a question for us. And then I also have a question if there's a gap. But I did want to just highlight, I see on the line also is Dr. Kevin Grumbach, and he was the department chair who allowed us to have this partnership between UCSF and Aga Khan University way back in the day. And so I just wanted to acknowledge him and thank him for that. So I wanted to just give you the very first question, which is Anjana Sharma says, thank you so much for joining us. And there is a consent that we have to agree to when we sign up. But could you tell us a little bit about how the data is shared with OpenAI as a partner or any other entities? It'd be great to learn about that. It looks like there is some retention of de-identified data.
Okay. Yes, very good question. In terms of how this is shared, I think the key thing is, first of all, the people who access the platform, both as a student and as an educator, it's a code you're using. So it's not really open to anyone. So it's a code you're using. But by virtue of that being an LLM platform, we are aware that it can be open to maybe other sort of the open AI. That possibility is there. So the key thing is the platform provides that security of, as an educator, your case is only private to you, and you are the only one who can share it with the other students. But by virtue of it being within an open AI space, then we cannot really regulate that in terms of who else can access that. However, you are able to de-identify the patient. If, for example, you're creating a scenario, you are able to perhaps provide some pseudonymization so that even if the case is available to other people, then it would not really be linked to you in any way or another. So the key thing is, by virtue of using the open AI platforms, we really may not have a lot of control. Like any other generative AI, the data shared or available would be open to people out there. But the case itself, you are the only one who can share it with the students using the code. And so perhaps within that, it's able to provide some form of security. And you're also able to sort of provide a security or a platform where you know who is interacting with the case, and you know the response they're providing, and you're able to again monitor that as an educator from your end. I've tried to answer that as best as I can. But I guess in case of anything, we can still continue to engage.
Absolutely, we look forward to that. The next comment was, thank you for a very stimulating presentation. This is Dr. Kevin Grumbach. Great that this is available in a non-proprietary public good way. So thank you so much for developing this with your colleagues and sharing it with us today. And then the next question is an interesting question. This is Joshua Connor, who asked, thank you so much. This might be more of a future version, but will there be an ability to add more nuanced challenges, such as patients who have PTSD or other personality traits, such as antisocial personality or co-occurring mental illness with common primary care presentations?
Oh, wow, that's a very interesting add. I think that's an addition to that. Perhaps already a bit of that can already happen in terms of, remember, you're tailoring the personality. So in terms of how you would want the conversation to go, a bit of that can already happen. But I see what you mean. To provide a more nuanced challenge like history of PTSD, yes, that can possibly, as we continue sort of developing this, that is something we can continue to add onto the platform. And even the co-occurring mental illness with common primary care presentation, that provides a good challenge. And I think we are quite open to that, and we will see how we can continue to integrate more and more of this within the platform. So thank you for that. But meanwhile, I really hope you'd be able to access that and see how best you can even try the different personalities. I think it's really, the sky is the limit based on how, you would be able to curate that based on your setting. So keep trying that also. And I think a lot more of this feedback will continue to stream in.
Excellent. And just to build off of that, Colleen Kiblahan chimed in that she completely agrees, and just thinking about trauma-informed interview and training for trauma-informed interview and how important that is, and then perhaps using national and international guidelines to use as the rubric.
Yes.
100%,
and I agree with that. And hence the idea around customization, because the guidelines we use in Kenya may be different from the ones you use here. So then that sort of allows one to customize it based on their guidelines, based on their context, based on the cases that they keep on getting, perhaps on a more recurring basis, and so that their residents or the students are able to interact with them. So 100% agree that, again, it will allow customization based on the guidelines that are available locally. And yeah, that's an add.
Great. Well, we typically like to end a few minutes before the top of the hour, because people will go into clinic and everything. So I think we could probably, given that there are no other questions, end here. But Dr. Gothi, thank you so much for leaving your email address and ways to continue to engage, because I think we did get a glimpse of the future of medical education in this presentation. Yes. As well as your discussion around precision medical education. It's exciting to see the ways that this could be leveraged to help us mitigate bias in medicine and enhance our cultural sensitivity with our patients. And you presented a lot of examples there as well. So I'm seeing lots of love come from the audience. Thank you so much, and we look forward to continuing our engagement.
Thank you again for the opportunity. Bye-bye.